Now let's talk about the home management of asthma. Early treatment by the patient at home is the best strategy for maintaining asthma exacerbations. Patients should be instructed how to 1. Use a written asthma action plan that notes when and how to treat signs of exacerbation. A peak flow based plan may be particularly useful for patients who have difficulty perceiving airflow obstruction or have a history of severe exacerbations. 2. We want to recognize early indicators of an exacerbation, including worsening PEF. Adjust their medications, number 3, by increasing SABA and in some cases adding a short course of oral systemic corticosteroids. Doubling the dose of ICSs is not effective. 4. Remove or withdraw from allergens or irritants in the environment that may contribute to the exacerbation. 5. Monitor response to treatment and promptly communicate with the clinician about any serious deterioration in symptoms or PEF or about decreased responsiveness to SABA treatment, including decreased duration of effect. The following home management techniques are not recommended because no studies demonstrate their effectiveness and they may delay patients from obtaining necessary care. Drinking large volumes of liquids, breathing warm, moist air, or using over-the-counter products such as antihistamines or cold remedies. Pursed lip and other forms of breathing may help to maintain calm, but these methods do not improve lung function. So, what is asthma? Asthma is a chronic lung disorder that causes airways, that's the tubes that carry air into and out of the lungs, to become inflamed, which means they will swell and produce a lot of thick mucus. The muscles surrounding the airways also tend to tighten, which makes the already clogged airways even narrower. This results in asthma symptoms, which can include coughing, wheezing, and shortness of breath. In a person with asthma, the airways are overly sensitive to certain things such as allergies, viral infections, cold air, exercise, and smoke. They can trigger or bring on asthma symptoms. People with asthma also find that their symptoms come and go. When the symptoms are present, it's known as a flare or a flare-up, episode, exacerbation, or attack. So now let's go over some key educational things to teach and reinforce. So basic facts about asthma. The contrast between the airways of a person who has and a person who does not have asthma. The role of inflammation. What happens to the airways during an asthma attack? Role of medications. Understanding the difference between long-term control medications that prevent symptoms, often by reducing inflammation, must be taken daily. Do not expect them to give quick relief. Quick relief medication. SABAs, or short-acting beta agonists, relax airway muscles to prevent prompt relief of symptoms. Do not expect them to provide long-term asthma control. Using a SABA more than 2 days a week indicates the need for starting or increasing long-term control medication. Patient skills. You want to make sure the patients are taking the medications correctly. Go over an inhaler technique. Demonstrate to the patient and have the patient return the demonstration. Use of devices as prescribed, such as a valve holding chamber or spacer or nebulizer. Identify and avoid environmental exposures that worsen the patient's asthma, like allergens, irritants, or tobacco smoke. Self-monitoring. Assess level of asthma control. Monitor symptoms and, if prescribed, PEF measures. Recognize early signs and symptoms of worsening asthma. Using a written asthma action plan to know when and how to 1. Take daily actions to control asthma, and 2. Adjust medications in response to signs of worsening asthma. Seek medical care as appropriate. Let's talk now about aerosol delivery devices, the age group, the optimal technique for each, and the therapeutic issues with each. Let's talk first about a meter dose inhaler, often referred to as an MDI. The population age group greater than 5 years of age. The optimal technique would be actuation during a slow, deep inhalation followed by a 10-second breath hold. The therapeutic issues here are slow inhalation, and coordination of actuation during inhalation may be difficult, particularly in young children and elderly. Patients may incorrectly stop inhalation at actuation. Deposition of 50 to 80% of actuated dose in oropharynx. Mouth washing and spitting is effective in reducing the amount of drug swallowed and absorbed systematically. So patients less than 5 years of age with spacer or valve holding chamber or mask. Under laboratory conditions, open mouth technique can be used. This enhances delivery to the lung. This technique, however, has not been shown to enhance clinical benefit consistently compared to closed mouth technique, which would be inserting the MDI mouthpiece between lips and teeth. Lung delivery under ideal conditions varies significantly between MDIs due to the difference in formulation. So, for example, inhaled corticosteroid delivery varies from 5 to 50%. So, a breath-actuated MDI. Patients greater than 5 years old, the optimal technique would be tight seal around the mouthpiece and slightly more rapid inhalation than a standard MDI, followed by a 10-second breath hold. May be particularly useful for patients unable to coordinate inhalation and actuation. May also be used for elderly patients. Patients may incorrectly stop inhalation at actuation. Cannot be used with currently available spacer valve holding chamber devices. So let's talk now about DPIs, dry powder inhalers. Patients greater than 4 years of age. You want rapid, deep inhalation. Minimally effective inspiratory flow is device dependent. Most children less than 4 years of age may not generate sufficient inspiratory flow to activate the inhaler. So the therapeutic issue, dose is lost if patient exhales through device after actuating. Delivery may be greater or lesser than MDI, device depending on the technique. Delivery is more flow dependent in devices with highest internal resistance. Rapid inhalation promotes greater deposition in larger central airways. Mouth washing and spitting is effective in reducing amount of drug swallowed and absorbed. So let's talk about spacer or valve holding chambers. In patients greater than 4 years old, slow, deep inhalation followed by a 10-second breath hold immediately following actuation. Actuate only once into spacer per inhalation. It's indicated for patients who have difficulty performing adequate MDI technique. It may be bulky, simple tubes do not obviate coordinating actuation and inhalation, so the VHCs are preferred. So the face mask can be used patients less than 4 years old on a VHC. If the face mask is used, it should have a tight fit and allow 3 to 5 inhalations per actuation. Rinse plastic VHCs once a month with a low concentration of household dishwashing detergent, 1 to 2 drops per cup of water, and let drip dry. The effect of a spacer or VHC on output from an MDI depends on both the MDI and the device type. Thus, the data from one combination should not be extrapolated to others. Spacer and or VHCs decrease oropharyngeal deposition and thus decrease risk of topical side effects. Also can be thought of as thrush. Spacers will also reduce the potential systematic availability of ICSs with higher oral absorption. However, spacers, VHCs, may increase systemic availability of ICSs that are poorly absorbed orally by enhancing delivery to lungs. No clinical data is available on use of spacers or VHCs with ultrafine particle generated HFA MDIs. Use antistatic VHCs or rinse plastic non-antistatic VHCs with dilute household detergents to enhance delivery to lungs and efficacy. The effect is less pronounced for albuterol MDIs with HFA propellant than for albuterol MDIs with CFC propellant. As effective as nebulizer for delivering SABAs and anticholinergics in mild to moderate exacerbations, data in severe exacerbations are limited. Able to identify and avoid environmental exposures. You need to know what sets your symptoms off, what triggers, whether it be cigarette smoke or dog dander. You need to be aware of those things for your protection against an exacerbation. Next, you need to be able to self-monitor. So you need to know the signs and the symptoms of when an asthma attack is coming on so you can prepare yourself. And you need to develop and review an action plan. This is an action plan for a child. Pretty much it's going to list the medications the child's on, what to do in case certain symptoms develop, and so forth. So other people, and when the child's at different places, will know how to treat the child. Thank you for watching Asthma Education.